Hi, everybody. This is Lori Tischler. I'm the section chief for general internal medicine. And this talk is to review all of the other talks that were in the section. When I'm not at this course, I'm the Senior Vice President of Medical Services at Commonwealth Care Alliance and a member of the Department of General Medicine at Brigham and Women's Hospital. So what I'm going to do is I'm just going to share with you some of what I thought were the most salient points from each of the wonderful talks that we've had in this section. Let me just start by saying that I have nothing to declare and no conflicts of interest. We'll start with geriatrics, which, as you'll remember, was Suzanne Solomon's talk. And here were some of the main points that Suzanne brought up. A total knee replacement for people who don't need a lot of support can be just as good at home in terms of people's ability to recover and do well as when they go to inpatient rehab. Certainly in the time of COVID, when many of our patients don't want to go to the hospital or to rehab, this is a positive development. She also found that when we see small vessel disease on MRIs in our geriatrics population, that this can correlate with an impact on patients' balance and gait. So reminding our patients about that when we share MRI results and ensuring that we're doing everything that we can to help prevent them from falling. Finally, in this study that I thought was very interesting is that most vitamin B12 injections that I think have been the mainstay of B12 treatment for many of us through our careers are prescribed to people who have no evidence of B12 deficiency. Furthermore, oral B12 at 1,000 micrograms is adequate to treat pernicious anemia and a both effective and cost-effective alternative to B12 injections. When you look at the cost of a shot of being between $20 and $77 a month versus 3 cents for a pill, it makes good sense to try the pills for the patients who will be able to do that. Additionally, Suzanne pointed out that doing an amyloid PET scan does in fact change care for people with dementia. When an amyloid PET scan was done, researchers found that a positive result changed both diagnosis and clinical management within 90 days of the PET scan result. So I think this is always a question for us when we're taking care of patients with dementia, is what is going to change based on any study that we do. Additionally, many of my patients for many years have wondered if using vaginal estrogen confers a long-term cardiovascular risk. Doesn't seem to confirm long-term risk for women with and without a uterus. For some patients, the risks were actually lower of using vaginal estrogen than non-users. In Ann Pinto's board review, I'm going to share some things that I thought were the most salient from her wonderful tour de force talk. First of all, for resistant hypertension, which is hypertension that remains out of control despite treatment with 3 drugs and presumption of adherence, the guidelines recommend spironolactone as the preferred medication for resistant hypertension. Fortunately, those of us who care for adults are caring for many, many more survivors of pediatric cancers. The important thing to remember is to have a high index of suspicion in a cancer survivor for serious issues, even in young people. You want to consider appropriate treatment based on the type of cancer that the patient had and the anatomy that may have been affected by treatment. And this has come up in a number of our other talks as well. For secondary prevention of CVA, antiplatelet agents are useful for secondary prevention, and the guidelines recommend either aspirin plus dipyridamole, or clopidogrel. And we see decrease of 22% on average when we are treating patients with antiplatelet medications. Finally, just a note that the GOLD classification for COPD has been updated to include symptoms and functional capacity and not just spirometry alone. So I think as you know from taking care of patients, all of these things do carry into somebody's overall capacity. So these are important things to ask. Dr. Plutsky gave us a wonderful talk on hyperlipidemia, and this is the answer, or one of the answers, to who benefits from a statin. One of the things he talked about in his talk is not treating LDL to target, but using high or moderate intensity statins. So for people under 75 with atherosclerotic cardiovascular disease, a high intensity statin makes sense. A moderate intensity statin for people over 75. Anyone with an LDL greater than 190 should be on a high intensity statin. And for our patients between 40 and 75 who have diabetes and an LDL between 70 and 189, you're going to want to use a risk calculator. Their 10-year risk is over 7.5%, high intensity, less than 7.5%, moderate intensity. Finally, for those of us in our middle years without atherosclerotic disease or diabetes who have a 10-year risk of greater than 7.5%, we would want to consider a moderate to high intensity statin. These are people who are at very high risk for future events. If you've had multiple major atherosclerotic events, you've had a stroke and an MI, for example. Or if you've had one of those events in the top 4 categories, but you also have multiple other high-risk conditions, diabetes, hypertension, you're a current smoker. And the key thing that Dr. Plutsky talks a lot about is not giving up when a patient believes or is, in fact, intolerant to statins. There are a lot of ways to help patients get through statin intolerance. And for some people, this may be an indication that it would be helpful to send the patient to a lipid clinic who will work through the statin intolerance with the patients, because they're wonderful drugs for people if they're able to tolerate it. Dr. Plutsky also mentions in his talk that elevated lipoprotein A may be in fact an unmet need with respect to risk factors. So I urge you to continue to watch the data and the literature for that. Next, we move on to Maria Yilamis's morning report. Maria is an endocrinologist and shared with us some wonderful cases about endocrine abnormalities, reminding us on the left of patients who present with secondary hyperglycemia, that meaning hyperglycemia who are not diabetic, to consider acromegaly, Cushing syndrome, pheochromocytoma, adrenal insufficiency, hyperthyroidism, a glucagonoma or somatostatin secreting tumors, pancreatic disease, and of course, medications. On the flip side, patients who have hyperglycemia with a normal A1C, we have to consider, is the glucometer working? Number one, probably. What's the timing of our testing and the assay? But there are other reasons that this can happen, and it can happen because of treatment of iron, folate, or B12 deficiency, or hemolysis. So when the A1C doesn't work to monitor a patient with diabetes, you want to use fructosamine, which looks at other glycosylated end products. This was also extremely helpful for me in a patient who had very high fetal hemoglobin, and because of that, we were getting persistently unusual results. Maria also talked about common causes of fever of unknown origin in her case. And these are all causes worth kind of knowing, of course, and having in your back pocket. But her case was one of the rare miscellaneous causes. thyrotoxicosis due to amiodarone toxicity. Other rare miscellaneous causes include atrial myxoma, familial Mediterranean fever, histiocytosis, pheochromocytoma, and Whipple's disease. Dr. Lisa Lehman talked with us about end-of-life care and advanced directives. And I wanted to talk about two things. What are the indications of talking about somebody's wishes in an advanced directive? And I think some of us in primary care would argue having a patient in front of you is a good reason to talk about people's goals of care, even when they're healthy, to make it normal. But routine indications that Dr. Lehman spoke about were patient who is in the hospital with COVID-19, anytime we're discussing a poor prognosis, or a treatment with a low probability of success. When you as a physician would not be surprised if the patient died in 6 to 12 months. And finally, as I said, anytime you're reviewing healthcare maintenance, I think it's key to at least help the patient think about if they were unable to make a decision, who would they want to make that decision for them? Urgent indications, of course, are imminent death, a patient thinking that they may want to die, recent hospitalization for progressive illness of any sort, and certainly if the patient had a poor prognosis and was suffering. There are some really important benefits to talking about end-of-life care and advanced directives. First and foremost, it allows the patients to give voice to their preferences, even if they can't speak for themselves. And it gives our patients peace of mind that their preferences will be respected. Benefits for us as healthcare providers is that it avoids future confusion and conflict, especially in the setting of urgent need. And huge benefits for families in decreasing their anxiety about the decisions they make at the end of life. You know, having been in the position of making some very serious decisions for a family member as the healthcare proxy, it is extremely relieving to know that you are making the decision that your loved one would have chose. If the treatment doesn't work, it also helps diminish the guilt of the family. And there are certainly advantages for our patients. Decreased ICU admission, we often see improved quality of life. Sometimes when people back off on their treatments, they do better for a period of time. Increased hospice use, improved bereavement outcomes for families, and having these conversations and making the decisions does not impact the therapeutic relationship between the physician and the clinician. And it really is best practice. You want to not undermine the patient's autonomy. You want to base what you're talking about on the clinical situation, the goals of care, and the patient values, and reflect back to that patient. I am hearing that what's most important to you is that you are able to go to the beach with your family in a month. And it offers guidance and relieves patients and families of some of the burden of decision making. It is okay to offer a suggestion to patients of what in this situation would make the most sense to you. I think we have to understand that the patient may not agree, and ultimately it's the patient's decision, but I think it's our responsibility as clinicians to offer our guidance and expert advice. Finally, moving into the biostatistics for the boards. This is Dr. Julie Buring, and I would say if the last 5 months of COVID have taught me anything, it's intense gratitude for my knowledge and understanding of biostatistics. For those of you who are taking the boards this year, there really are a limited number of necessary concepts, and Julie did go over all of them. More importantly, and all the time, using biostatistics is a way of thinking, and you should use and trust your instincts. You should, be able to think about why somebody would be more likely to have a false positive COVID test versus a true positive COVID test, and have an understanding of incidence and prevalence based on this. Some of it is truly common sense and sort of slowing down and thinking about what makes sense given the situation. A reminder, certainly, that the criterion of positivity, meaning where you set the test to be positive, will influence both sensitivity and specificity of the screening test. Positive predictive value also affected by sensitivity and specificity, but increased mainly by an increase in underlying disease prevalence. So if we're screening someone with BRCA1 or 2, we're going to assume a higher positive predictive value, for example, for the gene tests, or we may have a higher positive predictive value when we think about what we see on a mammogram or an MRI. Moving on to our discussion about obesity by Dr. Caroline Apovian. Here's some things to think about. Caroline really encourages us to think about obesity as a chronic disease. So you want to use patients' body mass index to identify risk. Very easy to do that. If you don't have something, there's an app for that. I could guarantee it, but you can also look on your computer. Using a patient's waist circumference to identify risk, and help a patient head toward a goal of 3 to 5% of sustained weight loss reduces risk factors and reduces the risk of developing diabetes. It's helpful as we think about other chronic disease to think in terms of prescriptions. What is a set number of calories per day? There is no perfect diet. And we want to advise obese adults who meet criteria that medication and surgery may be an option. Dr. Apovian recommends that pharmacotherapy should be considered with body mass index of greater than 27 with comorbidity, or greater than 30 without. And bariatric surgery may be considered with a body mass index of greater than 35 with comorbidities, or greater than 40 without. Again, these should be used as adjuncts to behavioral modification to reduce food intake and increase physical activity whenever possible. And Dr. Apovian goes into great detail about how and when and what medications to prescribe and surgeries as well in her talk. The goal for someone who we're trying to help lose weight should be to decrease their body weight by 5 to 10%. We want to accept steady incremental progress to get to goal, to help them focus on behaviors such as reducing caloric intake and increasing their physical activity. It doesn't have to be fancy. They don't have to join a gym. They can go out, they can take walks, they can even, for our patients who are more shut in, they can walk in their homes, and all of that stuff counts. Again, the goal, short-term, 5 to 10% weight loss at 6 months, with the goal of maintaining. If someone in the long term, we can calculate their additional deficit, energy deficit, for their next weight loss goal, right? We want to help people set realistic goals, but certainly not stopping them from losing more weight if they are able. And finally, as we think about whether the medical treatment is effective or ineffective, if someone has lost greater than or equal to 5% of their body weight at 3 months and the medication is tolerated well, we should continue it. If they have not achieved 5% body weight at 3 months, or safety or tolerability is an issue, then it's time to discontinue the medication, consider a different medication, or consider referral to an obesity clinic for alternative therapy. Obesity, as I think many of you are probably aware, has emerged as an important risk factor for young people who have COVID-19. The first 393 patients at New York Presbyterian Weill Cornell Medical Center did identify obesity as a risk factor. And it's important to realize that, that among our younger adults, less than 54, half of them live with obesity. The New York obesity rate is lower, possibly because it's a city and people walk more, but at any rate, it was identified as an independent risk factor, and the issues, of course, relate to our ability to care for people, including difficulties in intubation, challenges in obtaining diagnostic images, patients more difficult to position and transport, and they may also not do well with proning, turning them over on their stomachs, which has shown to be extremely helpful for some COVID patients. Not all countries and not all hospitals have special beds and equipment needed to take good care of people with moderate to severe obesity. And the COVID crisis has shown that this is an even greater limitation. Dr. Sarah Wakeman came and spoke to us about opioid use disorder. And I share this slide, this graph, to say that when we expand our ability to provide medication-assisted treatment, overdoses decrease. So they actually save lives. France basically expanded access to buprenorphine. They didn't have required physician training, patient limits, no requirements. 90,000 people treated with buprenorphine, 10 with methadone, and we saw a 5-fold reduction in heroin overdose deaths, a 6-fold reduction in active IV drug abuse, and a decrease in HIV prevalence. Medication-assisted treatment really does save lives and improve quality of lives. Basically, behavioral interventions are wonderful when we can use them. But if our behavioral interventions are not available, don't withhold medications to treat opioid use disorder. The percentage of adults who were prescribed any level 2 or 3 opioid decreased from 12.9% in 2014 to 10.3% in 2016. Adults who had moderate to severe pain were more likely to have their medications decreased than those people who had less pain. And of note, the largest reduction in opiate prescribing occurred among Black adults and people with incomes below the poverty level. With respect to that last bullet, we need to be consistently thinking about our own implicit biases. A study was done of 222 white medical students and residents. About half of them endorsed at least one false belief about biological differences between Black people and white people. And those who endorsed, the higher number of false beliefs that the students endorsed, the less likely they believed that a Black patient was feeling pain. So given our world, our climate, I encourage you to really be thinking about the way we approach our patients, judge our patients, and teach others about taking care of patients. People who are at greatest risk of death from opioid overdose are often the most marginalized. And these, for example, the opioid death rate is 16 to 30 times higher for individuals experiencing homelessness. And again, 120 times higher for an individual who has a history of incarceration. Our treatment models are generally not designed with patients like this in mind. And that's where we as clinicians and people like Dr. Wakeman as an opioid specialist need to be really creative to think about what we can do to save lives. The overdoses have surged amidst COVID. And you can see from these slides that after the lockdown in Cook County, Illinois, which is Chicago, overdoses went way up. And during the first 4 months of the pandemic, overdoses rose up to 42% per month compared to this previous year. So it's a just under 50% year over year increase. And that's actually the last slide. I am really happy that you've participated in the course and in our wonderful general internal medicine section. And I hope that it's been a good experience for you. It certainly has been for me. Thank you very much.